My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to this ACMT special webinar entitled Telehealth Visits to Support Medical Toxicology Practice in the Time of COVID-19. Today we'll be discussing the brand new way we can provide toxicological consultation and advice through the telehealth mechanisms that have been newly deployed during this public health state of emergency. The talk will be predominantly given by my colleague, Dr. Timothy Wiegand, who's a member of the Board of Directors of the American College of Medical Toxicology and also sits on the Board of Directors of the American Society of Addiction Medicine. Tim is an Associate Professor of Emergency Medicine at the University of Rochester. Next slide. The objectives for this webinar is understanding the changes in regulations regarding the provision of telehealth due to the emergency, see how quickly one can set up your own telehealth practice, and to learn about medical toxicologists' experience with telehealth. Next slide. This was a directive from the governor of Arizona that came out just yesterday on the 25th of March. I'd like just to briefly highlight some of this directive just to show you how rapidly the landscape for delivering telehealth is changing. I'd also like to add that many, if not most states, are putting out similar directives, but the provision of telehealth is typically regulated on a state-by-state basis. So the beginning was that whereas we were in a public health emergency by the COVID-19 affecting certain populations, and that the CDC recommends that health insurers and providers promote the availability of telehealth services, and also that the spread of COVID-19, the danger the virus poses to at-risk populations, and the need to protect our healthcare workers requires an expansion of telemedicine. Next slide. Therefore, beginning on March 25th, which was yesterday, and continuing for the duration of the public health emergency, all health insurance plans regulated, in this case in Arizona, are hereby required to provide coverage for all healthcare services that are provided through telemedicine if the healthcare service would be covered were it provided through an in-person visit between an enrollee and a healthcare provider. Next slide. Insurers must reimburse healthcare providers at the same level of payment, which is parity, for telemedicine visit as they would for an in-person visit. Insurers must allow all electronic means of delivering telehealth, including telephone and video calls. I should just add that in the past we've often addressed telehealth as requiring video conferencing. That is no longer the case. Telephone calls by themselves will account for telehealth delivery during this emergency. To enable individuals to remain in their homes, insurers shall allow a patient's home to be an approved location to receive a telemedicine service. That the Arizona Care Cost Containment System shall require all Medicaid plans to cover all healthcare services. That no Arizona regulatory board shall enforce any statute, rule, or regulation that would require medical professionals licensed by that board and is authorized to write prescriptions to conduct an in-person examination of the patient prior to the issuance of a prescription. And there is an exception to that, which Dr. Wiegand will go into, but most prescriptions can be written, not all, but most can be written without a face-to-face encounter. And the executive order does not expand the scope of the practice for any licensed provider type. Next slide. Finally, the executive order expires upon the termination of the declaration of the public health emergency. So in summary, the landscape for delivering telehealth has radically changed overnight, just within the last days and hours. And this presentation will now present to you the changed landscape and the opportunities for medical toxicologists to continue to provide our consultative services via telehealth. And at this point, I'd like to turn the presentation over to Dr. Wiegand.
Thank you, Dr. Wax. I want to remind everyone that this is what we know as of the 26th of March, and things are changing on a day-to-day basis. To start, telemedicine isn't new for toxicology. As Dr. Wax mentioned, regulations and governing the use of telemedicine and reimbursement varied on a state-to-state basis, with some federal regulations as well. Normally, you need privileges to do telemedicine, and I've included an example of the telemedicine privileges to provide toxicology that I had previously. We've been doing some components of telemedicine at the U of R in New York because there has been parity since 2016, and I'll refer interested individuals to some of our published experiences regarding this. You normally would get set up with your hospital as the hub site and be able to deliver to remote sites or the spoke sites, or be able to deliver telemedicine support back to your hub site while traveling, for example, or overnight back to the hospital or emergency department if you're not in person. Right now, most of the hospitals and systems and centers are getting set up to provide telemedicine, or have been over the last 2 weeks, and many states have issued a state of emergency, and there's also federal guidance that we'll discuss. Refer you to your hospital and system support teams. There's often platforms that are set up, and smart phrases and particular ways of utilizing your electronic health record. We have EPIC at the U of R, and I have some experience and information if individuals are interested. In general, you'll need an introduction for the patient encounter, whether it's for clinic, whether it's supporting them in the ED or in the hospital, and then have an attestation, and we'll talk a little bit more about what that means. You typically would need consent to do a telemedicine encounter for a clinic patient and at the bedside. Consent now can include verbal consent, simply documented while the telemedicine encounter is being, or telehealth encounter, whether it's phone or direct audio video, is being performed. For even the CFR 42, the higher level of confidentiality that's required by the federal programs that are providing care for the treatment of substance use disorder, verbal consent is allowed in this emergency while the state of emergency, and you should have an attestation that indicates that whoever you're providing the telehealth support to is given consent. In general, I have an introduction that would go something like this. This encounter is a telehealth visit during the state of emergency related to COVID-19, and I'm authorized to perform telehealth via phone, audio, video visit in lieu of direct clinic or bedside encounter as a consultation or clinic visit. This is a billable service, and the same copay, deductibles, insurance coverage apply. Do you agree to proceed? And then document where the patient location is, whether that home or if they're in the ED, or if they're in a hospital unit, where your location is, if it's a home office, a clinic, administrator's office. Was anyone else present for the encounter? Residents present, administrative assistant present. Any interruptions to the service, dropped line, had to recall in, and whether the patient agrees to proceed. Wanted to cover a little bit about the Department of Health and some particular situations where telemedicine was not allowed, that it is now allowed, and that is when you provide a controlled substance for the first time. That historically has required a direct in-person visit, and while the font is small, I just wanted to include for reference and resource, the Secretary of Health and Human Services has issued a exemption during the time of emergency where as long as a public health emergency is in effect, a DEA-registered practitioner may issue a prescription for controlled substances to patients for whom they have not conducted an in-person medical evaluation if the prescription is for a legitimate medical purpose and the practitioner is acting in the usual course of practice. Telemedicine communication is conducted using audio-visual real-time two-way interactive communication, and then the practitioner is acting in accordance with federal and state law. So this would apply when you're, for example, starting buprenorphine in a patient in the ED or in a clinic setting, and you have not had that initial face-to-face visit. The first encounter is required to be a direct audio-visual encounter, after which in New York State and where the other states, such as Arizona, have issued a state of emergency, you're able to follow up with phone encounters and continue to be reimbursed at parity to the bedside or in-person visits. So a little bit about billing. I've included some billing facts that we'll cover throughout the presentation and then have some time at the end. Billing for telemedicine will depend on which CPT code is used, which means which encounter is used. There's still phone encounters or phone visits, which include just simply contact with a patient related to an appointment or a medication refill or interpretation of lab data that really wouldn't include the same components as a clinic visit, where you would include a follow-up visit note or an initial encounter in the emergency department that requires a history and physical for a standard toxicology assessment. And those CPT codes are included here, the 99441 through 443, generally time-based. There are some specific CPT codes for particular specialties, OB, behavioral health. There's comprehensive lists available that I'm not going to get into. In New York State and in many states and for many federal services, there's parity for whether the provider performs direct audio video, so the standard telemedicine encounter with real live interactive session via audio video. If that's not able to be performed, a phone encounter could take place with parity for reimbursement. The components for that encounter, however, need to include all of the standard components that you would do if you were doing a face-to-face assessment to get that level of billable service. So if I'm doing a consult in the emergency department, a child ingests a medication that fell out of mom's purse, and I'm at home and don't have the video set up, or I can't for whatever reason do the video, I'm quarantined, and I'm on the phone with mom and the ED provider, I would document a history and physical and document all of the components and indicate that that was a telehealth encounter and it was a history and physical. It would be a phone encounter, but I would not bill as a phone visit like I indicated subsequently, comparable to like a med refill or scheduling an appointment. You would use the phone, but you would bill for the encounter as a history and physical, and we'll talk about what codes to use. Earlier today, we had a toxicology clinic, which is a long-term stable maintenance clinic for patients on medications for opioid use disorder. And normally I bill using the 99211 through 99215. Starting last week, we had converted all of our clinic visits to telehealth encounters. And for most of them, we decided to use the Zoom platform, which is the platform our university prefers us to use. A couple of individuals I could only do the phone encounters for. For these encounters, even though it was telehealth and some were audio video, a couple were phone, we documented using the appropriate complexity. The notes were essentially the same, just indicating that I conducted the visit via telehealth. There is some front-end administrative work where the patients need to be entered appropriately under a telehealth encounter, otherwise it will throw the system off for billing. So you really need to work with your administration and billers coders on how to enter patients, indicate that the encounter is a telehealth encounter for the purposes of reimbursement. And there's different CPT codes for whether they're new patients or existing patients, and these are time and complexity based, and we've previously discussed this. Not all telephone calls should be billed. Some can be billed under routine phone service, and we've had some discussion in the past about billing for toxicology encounters just for routine phone follow-up when a normal assessment, exam, H&P, or subsequent visit level of care doesn't occur. So not all phone encounters are going to be reimbursed at the levels consistent with outpatient clinic visits or bedside encounters. If a resident participates or a trainee residents, you can't bill directly for the resident performing the work, but if they perform the evaluation and then you subsequently or in conjunction with the resident see the patient and sign the attestation indicating that you have directly examined the patient and performed all the normal evaluations and assessments that you would at the bedside, you can bill when the resident sees and puts a note in. You just simply sign the attestation. and whether that's via phone or via direct audio video, you can do that with the resident evaluating the patient. This is the attestation that I use. We have a smart phrase in Epic. It's indicating that we perform the service via telemedicine, indicating real-time audio-visual, patient located. We would indicate at home or in the clinic, or earlier today I had most patients at home. I had one gentleman that was at work that stepped into a room where he could be away from anyone else and was able to talk freely. I had one gentleman that was driving into work for an emergency that pulled over and stood behind a gas station while we had our clinic encounter for 15 minutes, and the patient said he was comfortable with that as we proceeded, and we had good connection. So you just want to indicate where you're doing this and where you are and whether anyone else is involved, and then also whether the encounter had any drop time or any interruption in service. For Medicare patients, if you perform a telephone or other telehealth evaluation, there are specific modifiers that you're going to use, and this is something you'll just need to work with the billers and coders to indicate, to make sure that you're using the appropriate CPT codes and modifiers. For non-Medicare patients, for phone, when you perform just in general, and this is just the phone encounter, not the full clinic visit or history and physical initial encounter in the ED or hospital or subsequent visit, the CPT codes are 99241 through 43, and those are just generally time-based, and this would be just simply a brief phone note entered in the computer, and these are reimbursable just at lower rates than the standard encounters. For the bedside and the ED and the hospital encounters, the CPT codes typically are G0425 through 427, which include a focused or detailed or a comprehensive assessment. These are time-based. Modifiers would include where the patient was, inpatient, you'd have a modifier of 21, office of 11, emergency department of 23, and then use the modifier GT to indicate that it's a telemedicine encounter, which you would also include in your note. We've previously published our experience performing telemedicine, telehealth, audio-video support to patients in the ED, in the ICU, to various parts of the hospital, most of the time using the G0425, which is the lower amount of time. And New York State had parity for reimbursement at the time, so the payments to the service for performing the telehealth encounters is included here, and this is from a 2018 publication. This would essentially be the same if we were performing now. The only difference is I could perform these encounters using a phone in addition to using audio-video if I couldn't use audio-video to perform the assessment, and I would include the reason why, that it's a state of emergency due to COVID, and we would still have parity or expect the same reimbursement. I just got communication actually today from Excelis that for the state of emergency, the telehealth encounters related to COVID, they're reimbursing at 1.5 times what they had for standard reimbursement. So there's an incentive for healthcare providers to continue providing support. And this is from the publication. I'm going to skip that. It's just some data on our reimbursement in the past. A little bit about telemedicine in other areas where many toxicologists are practicing. That's the outpatient clinic and substance use disorder treatment world. Telemedicine has been used pre-COVID for buprenorphine support in many settings. Because buprenorphine is a controlled medication, in the past, pre-COVID, all of the initial visits needed to be in person, not via telemedicine. If a patient was going to be doing a home induction, they had to meet with the provider in advance, face-to-face, and subsequent visits could be done via telemedicine, although the site where the telemedicine occurred had to be specified. There's limitations. The provider couldn't be at home doing this. For naltrexone, the initial and follow-up visits could be done just simply with telemedicine, no in-person visit. However, obviously, to give an injectable naltrexone, patients need to be on site. Currently, the outpatient treatment program, where I'm medical director, the only patients that we have coming in right now are the ones getting the injectable buprenorphine or the injectable both naltrexone, extended release naltrexone, and we have a crisis mechanism that few patients are also coming in where they don't have other options. For methadone, all initial and follow-up visits needed to be in person. There was not telemedicine allowed. For Medicaid patients, providers needed to be in a clinic site, and patients needed to be in a clinic site too. These could be different clinic sites for telemedicine. And the platforms used were limited to only a certain type delivered via HIPAA-compliant two-way audiovisual platform. Telephone visits were not permissible. Telehealth NOW, in the context of the COVID emergency, for buprenorphine, all visits can be via telemedicine, both the initial and maintenance. Home induction can occur via telemedicine. That first visit, though, well, it's prescribed. You need to have the video component. For naltrexone, all visits can be done using telemedicine, whether audio, video, or phone, and obviously the injection still needs to be given on site. For methadone, in an opiate treatment program, the federally licensed opiate treatment program, the initial visit must be in person, not via telemedicine when the patient's getting assessed for methadone, but the follow-up visits between the provider and the patient, the physician doing the prescribing, the advanced provider, they can be done via telemedicine. For all telemedicine visits, regardless of insurance, both the provider and the patient can be at home, not at a clinic site. And telemedicine does not need to be delivered via HIPAA-compliant platform, including for 42 CFR Part 2 covered patients. It can be done using a variety of different platforms: FaceTime, Skype, WhatsApp, Facebook Messenger, Google Hangouts. There are some where it is not okay, not permitted. That's Facebook Live, Twitch, TikTok, so just be careful what you're using and find out what the best practice associated with your hospital is or what they're making available. Often there's going to be the platform that is widely available to medical staff or faculty practice. Telephone visits may be used for follow-up for medication for opioid use disorder appointments, but not the initial patients for buprenorphine, as I've mentioned. I've included some regulations regarding the current regulations in the state of emergency for telemedicine, and not going to go over these in detail. They're simply for reference if one wants to follow up with the regulations and look at some specific details. We've discussed the Secretary of Health and Human Services public health emergency and what that created in terms of exemptions to being face-to-face for that first in-person visit if you want to dig deeper into the regulations. And SAMHSA has waived the 42 CFR Part 2 written consent, and I've got some information about that here. For opiate treatment programs, all states with declared states of emergency, the state may request blanket exceptions for all stable patients in New York. There's basically two types of take-homes for most opiate treatment programs: the 28-day take-homes for stable patients, and then the 14-day take-homes for unstable patients. And this has implications beyond anybody practicing in the context of an opiate treatment program. The emergency departments, urgent cares, other providers are going to see patients that take extra methadone, run out, have it stolen, and will need to work with the opiate treatment program, or at least have a contingency plan on taking care of these patients, whether it's for overdose or how to, support them for withdrawal if they're missing their methadone. Other services. Services still need to happen in the time of COVID-19. I've got a peer counselor that's doing naloxone training, overdose prevention classwork through the internet. The AA, NAHA, or Heroin Anonymous meetings are available nationally as well as at the state and local level through Zoom meeting and a variety of internet platforms. We're using telemedicine, audio, video to do some check-ins with patients, observe doses, a lot of different things. Providing addiction care, there's a lot of changes now. There's that I'm not going to get into during this visit, but I'm happy to answer questions after. And we're having some other webinars related to addiction toxicology that I'd encourage people to log into because a very different landscape. We'll talk a little bit about the different platforms available to provide telemedicine support. I'm mostly using the Zoom platform. I've got colleagues that are using some other platforms. We've had phone contact where clients and patients aren't able to figure out the app or download, and learning on the fly. Dr. Wax is going to talk a little bit about some of the options that he's becoming familiar with, and then we'll take some questions. We have some time for questions at the end. Dr. Wax.
Yeah, thank you, Dr. Wiegand, for really a great presentation put together literally within the last 24 hours as the landscape has markedly changed. And we're coming to the conclusion of this presentation, and then we'll open up for Q&A. Please, if you'd like to type in a question, you can type in a question into the Q&A, or you can raise your hand and we'll unmute you. So just as an anecdote, my wife is a gastroenterologist who had an office-based practice, and she was confronting the fact that she could no longer see patients in her office. And so literally overnight, she opened up her telehealth practice remotely using this software called doxy.me. The website is doxy.me. And next slide. And it's very affordable. In fact, you can even have a free version of the software. Otherwise, it's minimal charges, $35 a month for all the bells and whistles. Next slide. And this is the image. It's done on a plain laptop computer. The patient needs to have access to a video camera to use this sort of device. But this is the patient view. So the patient is seeing the physician in either his office or his home or some other sort of setting. Next slide. And this is the vision. This is the view from the physician. The physician is observing the patient. Again, the patient and the physician both need to have video camera capability. And the next slide. And this, in fact, I believe is a HIPAA-compliant system. One can schedule appointments, and in fact, my wife is now seeing over 20 patients a day through this means of communication, something that can be set up very quickly. So this is nice for an outpatient setting. Whether it would be as useful for an inpatient setting is to be determined. Next slide. And you want to go on with this?
Thank you, Dr. Wax. And from what I understand, I have a colleague using that platform. One of the nice things is that patients don't have to download an app to then actually access the platform like they would with Zoom meeting. That's usually the hang-up is the individuals accessing the Zoom meeting app. If you were in the hospital performing back to the ED or one of the units, you'd ideally, if it were direct audio video, have someone with a laptop and the platform installed and be ready to access. If it were directly to a patient at home, they would have the platform that you're using, and the platform that Dr. Wax just showed is a very simple one from what I understand. I'm going to look at that as well for one of the settings. So I just wanted to talk a little bit about different opportunities. We've talked about some of them for providing telemedicine, telehealth support. There's the standard bedside consultations that most of us are doing in our toxicology practices to the ED in the hospital. And God forbid someone's quarantined and is not able to be in the hospital or even at home remotely, and they're consulted. Telehealth support can occur back to the ED or the hospital and critical care units. The clinic support, the patients can stay home, which is what we've done the last couple of weeks from our toxicology clinic, most of which are long-term maintenance patients. We've got a couple of standard toxicology patients that we use to support as well, lead, level monitoring, some other things. Rapid clearance from the EDs. The hospitals are increasingly inundated with COVID-19. It's critical to get patients out or potentially to have an option to follow them up. We have a plan to support patients that are not able to access the outpatient programs for opioid withdrawal or even detox to quickly assess them in the ED and potentially then follow them through telehealth visits after the initial ED contact for alcohol withdrawal using ambulatory protocols and for medication for opioid use disorder, outpatient treatment, we've covered that. Counselors as well. I wanted to just mention that in the outpatient treatment programs, counselors and health home support are also now allowed to do telehealth encounters, and some of the groups that are in the outpatient setting are occurring via telehealth. Some limitations, obviously, if your patients have phone minutes, access to the internet problems that are barriers to some patients, and there's huge opportunities for toxicologists to be available as the inpatient units and detoxes are either closing doors, potentially in many areas, or even whether they stay open as they can't take the number of patients that they have to be able to support in your clinics, if that's part of your practice, to support patients with substance use disorders or buprenorphine or for alcohol withdrawal. So lots of opportunities, and as you're getting familiar with this now, I'd encourage everyone to make sure they continue to use telehealth, become credentialed, and get privileges after these emergencies are over, because this is going to, the state of emergencies will be lifted at some point, but we'll still have an expanding role for telehealth. We've got some resources. We're also going to make additional resources available. We've got a couple of PowerPoints, if you use Epic in particular, how to put in Epic telehealth encounters, some publications on the use of telemedicine to support toxicology. Many toxicologists have been doing this using unique platforms, Google Glass, and other ways of communicating with patients historically. So there are some really interesting publications out there. And if there's any questions now, we'll open it up to attendees for discussion.
Okay, great. Well, thanks again, Dr. Wiegand. There are several questions that were typed in. One question from one of our participants says, I am an ER doc and tox trained, but not currently contracted with a medical toxicology role. I imagine I would not be able to bill, which Tim, you can comment on, but would I be covered under these policies to provide a free service for my hospital during the COVID pandemic national emergency? In fact, I'm going to, if you unmute Michael Connolly, maybe you can explain a little bit more what he would like to do.
Sure, I've unmuted you, Michael. Go ahead.
Yes, hi. Can you hear me?
Yes.
Yes.
Hi. Yeah, sorry. That's what I'm trying to say is so my role is just as an ER physician. I'm fresh out of fellowship, and so I don't have anything set up with my hospital system in terms of toxicology yet. So, especially at the beginning of the presentation, I guess more for like medical legal protection, would I be able to provide services, let's say, if somebody had a hydroxychloroquine overdose? And, are those the same protections for people like me who don't have something set up already or who are not credentialed for toxicology? Or is this really more specific to, toxicologists that have already credentialed in their hospital?
So it's interesting. You have different questions. You're talking about scope of practice, and the telemedicine isn't allowing for an expanded scope of practice. Like if I don't do OB, I'm not going to, outside of an emergency and no one else available. That's not my scope of practice. I'm not performing surgeries, but you are trained in medical toxicology, so you're just not set up to bill. So you would be able to provide support for medical toxicology, just not bill. You should be able to get set up very quickly with your billing departments, potentially using a separate tax ID. Very easy to get a separate tax ID. In fact, if you look at the most recent billing lecture, there's some instructions on how to secure a separate tax ID, and then you would bill not while you're doing your emergency medicine work, but you could bill separately outside of when you're doing ER shifts as a toxicologist, or you could just simply provide that as free support. I think many of us are going to get pulled into different areas. Like my primary specialty is medicine. I'm not credentialed to admit patients to the hospital, but I have a background in medicine and I expect to probably be doing some medicine, general medicine, in addition to medical toxicology.
Great, thank you.
Yep.
Okay, so next one we can Well, Christina Hansch is on. I don't know if we can unmute her, but she had several questions. The first one is, how can you do a telehealth visit with an intubated patient in the ICU? No visitors are out at the bedside, and the patient cannot communicate. I would assume that the critical care physician and the nurse is available at the bedside, but no family member. So that's the first of her two questions, Tim.
So that's a great question, and you're going to have to include the information that you have available. I would, if I was called to do an encounter, and actually this occurred the other day with one of our patients that came back, had a possible COVID exposure testing and had taken an overdose as they had gone home and come back. Document in the form that you would document as if you were at the bedside. So my note would indicate the history of present illness, the review system not able to obtain because of intubated patient, the social history, family history from review of records. The exam would be either as described or simply not able to do because not able to visualize, or reported from nurse and provider, data labs, and then assessment and plan. And I would document in the same format versus doing a phone note. A phone note would be, brief note called from the ICU, ask this question, and I would leave like a two-sentence note describing, my thought processes or basic information. I usually use phone notes when I anticipate on following up the next day directly at the bedside or later that day at the bedside. But if I'm not going to do that, I'm going to use the format and then submit under a telehealth encounter, just obviously not including the things that I'm not able to do because of the barriers in doing those things. Hopefully that answers that question.
Yeah, Tim, I have a follow-up question to that, which is, particularly with the telephone where you're not able to, to perform any physical exam other than assess the vital signs, perhaps, and or the video link where you may be able to perform certain components of the exam, but certainly not the full exam. Will that be down-coded because you don't have the usual number of elements for a comprehensive exam, or would there be any exception with this public health emergency that in lieu of not performing a full physical exam, you won't be demoted potentially?
I don't believe you'll be demoted or down-coded because of the emergency. You have to indicate that you're not able to do that because of whatever limitation. And there are certain things, when I'm on the phone with a patient, I'll document that they're pleasant, they're oriented, there's not slurring their speech, they're interactive, not confused, don't sound tired, things like that. On the monitor, there's certainly hitting almost all of the components, through a visual exam, just thinking, okay, well, what can I document from, they're not coughing, they're not tachypnic, they're not jaundiced and diaphoretic, they're not with myoclonus or slurring speech or overtly rigid, so there are an awful lot of components that you can get with the video. With the phone, I will bring that back to my billers and coders, but from what I'm understanding is that they won't be downgraded, although this is all new to everybody, obviously. In just a couple of days old, we'll still have to submit bills. I think the most important thing is that they're supported, and you're able to include these as a component of your practice. And for some of us, it is the reimbursement is important, but it's also value in other ways. You can track relative value units potentially as well to show your productivity. But and again, in the state of emergency, there's delivering care, offloading the ED. Doing your work, and you normally wouldn't be able to because you're not at the bedside. I think those are the critical things right now.
Okay, great. Thank you. So Christina actually had an additional question, kind of a two-part question, and it was about Doxy or I guess other sorts of platforms, but specifically for Doxy, which she said is preferred by her husband's by her hospital's new telehealth program since it is HIPAA compliant. And can this be done by sending the link to an ICU team member if the patient is not able to communicate? So do you have any? I realize Doxy is new to you as well, but if you sent the doxy link to the team member, the ICU, team member, is that the way one would do the doxy communication? And then the second part of that is if that was done, you would just document that as part of your documentation, I assume.
Yes, and in fact, even if the patient were in a program where CFR 42 applied, there are exemptions to the confidentiality in an emergency situation like that, because obviously if you're sending a link to somebody who's setting up a platform, for the patient, potentially you're breaking confidentiality, but in an emergency setting, that there is an exemption related to that for CFR 42. So yeah, I do that with the Zoom platform. I send the link to the residents, and they are at the bedside if patient's intubated. It doesn't go directly to the patient, or often we'll just hand the patient the iPad. Historically, when we published our data on our first series in 2018, that wasn't sending links to the patient. That was sending to the provider, and they were at the bedside.
Okay, great. Yeah, so if you could unmute Leslie Dye, she has a couple of questions about the billing.
Sure. Go ahead, Dr. Dye.
Leslie, you're on. Yes, we can.
Yep.
Hello?
We can hear you. You're good.
Can you hear me?
Yes.
Yes. Okay, I think she's
I don't know if anyone can hear me.
Yeah, why don't you mute her, Tim, and I'll read the question. So the first of her questions was just to be sure that for in-person time codes, that's the 99215 and the 99205, et cetera, to be sure to document that over 50% of the visit was spent in counseling, and that was what the counseling was, and that what the counseling was is clear. So I think the question is about the documentation of the counseling component of those two billing codes.
Yes, well, they can either be done via time or complexity. If you do them via time, which most of my clinic patients are going to be time-based because mostly we're doing counseling if it's for opioid use disorder, or even, much of the standard tox ends up being discussion and counseling. The attestation should include over 50% of the encounter was spent related to counseling, and then I include some information about what it in general was related to. So yes, but there's also complexity-based that you could do if you indicate that the complexity, and then you have to have the right components in the H&P and the review systems and the exam. So, and then there's some, I didn't mention additional codes that could be done if you're in a clinic. We had a couple of smoking cessation earlier today that had two people quit smoking. They're worried about the effects on the lungs in COVID-19. One quit vaping, the other quit smoking, and both made my day. Both have been off for a week. So, but that was another ancillary code that we added on top of the visit. So there are other opportunities as well, but you want to make sure your documentation is appropriate and all the attestations appropriate.
Okay, great. Thank you. So Jacob Pumaga from Dallas was wondering about seeing the slides with the CPT codes. Again, I will state that this presentation has been recorded and will be available tomorrow. And we're also going to put the PowerPoint presentation in the PowerPoint format up on the webpage. The webpage has already been created. It's under the ACMT webinars. You'll see it clearly. And the PowerPoint presentation will be available. So you can use the slides if you want for your own hospital folks, and you can copy any of the billing codes right off the slides.
And I have some other instruction regarding the CPT codes that we can post as resources as well, in addition to what's included here that we can make available.
Okay, so the next question is from Howard McKinney. It says, are telehealth consultations recorded for entry into Epic or other systems as chart notes? That's the first part of the question. The second part is, can other clinicians benefit from reviewing those chart notes, and what formats are recorded? And then also, I guess the additional question is, what formats are recorded, audio, video, transcription only, et cetera. So I think the question is about the documentation within Epic or other EMRs, and then if one uses Doxy or one of these other platforms, can the back and forth between the patient and the provider in some way be entered into the electronic medical record?
That's a great question. I have not done that. I don't believe so. I don't know of any cases, at least, that our institution people have recorded and then uploaded. There is a type of telemedicine and the historically very limited coverage and reimbursement for recorded telemedicine encounters where a patient would be interviewed and then you would go back and review and then so it was asynchronous. I don't record any of the encounters. I certainly would check with what your hospital policies regarding that. Mostly they're meant to be performed and then you document separately in the medical record this standard note. So none of what I've done I would upload either the audio or video or anything or save on my desktop or phone. I would caution against doing any of that. In particular, since later on that could be discoverable, and right now in the state of emergency, in particular, if you don't use the HIPAA compliance stuff down the road, if that's recorded, that could lead to some problems too. So I'd be very careful with recording anything.
Thank you. I'd like to make a quick announcement before we go on with some additional questions. So many of you on this webinar are involved with ACMT's Toxic program. Up until now, the Toxic program, the essential element was to report on bedside consultations only, whether it's in the hospital or in the clinic setting. Given the public health emergency, the Toxic team, Dr. Brent, myself, Dr. Kampelman, have moved quickly to adding an additional question to the Toxic form, which will essentially be, was the consultation performed virtually via telehealth, yes or no? And if the answer is yes, then it opens up to one or two additional questions. That will go live on April 1st. We certainly would love to encourage folks to continue their toxicology consultations. Patients and hospital systems need this now more than ever. If you start to develop this virtually, as we've described in this presentation, and you put together a formal note on the visit, not just some sort of curbside, but a formal note, H&P, then by all means record those cases in the Toxic Registry. It's going to be very important, and in fact, just yesterday, the FDA contacted ACMT looking for additional data regarding cases, toxicology cases that may have any sort of COVID-related issues, and we are going to develop some additional questions specifically on that for the Toxic Registry. So the FDA is quite interested in what the medical toxicologists are seeing, and also the CDC. We have a new relationship that's going to be rolled out with the CDC next month. So I strongly encourage you to continue your toxicology consultations, even if they're done remotely, and enter them into the telehealth as our public health governmental divisions are looking to the Toxic Registry and what medical toxicologists are seeing or seeing virtually for their mission. And if you have further questions, feel free to contact myself or Dr. Brent about that. So the next question is from Rob Ken, who says, if a fellow performs a telehealth consult, either audiovisual or the telephone, what is your understanding of the requirements that the attending needs to satisfy in order to co-sign or bill for that consultation?
They would be the same as if it were done in bedside, now with the exemption that you could do that via phone or telehealth as well. So you would have to have the same type of support or encounter as you were at bedside, but instead of being in bedside, you could do it via phone or audio video. I had a slide on that as well that described what the expectations were with resident and fellow support. But I had a chat
Does anyone
question.
else have any questions? You can raise your hand. I think of the folks that have their hands raised right now, we've addressed all their questions, but we still have a few more minutes in case anyone has additional questions.
I want to read a question from Dr. Christine Murphy. She has a question: are there changes to critical care billing or documentation requirements? Can we still bill critical care? And yes, as long as the standards are met, it's life-threatening, imminently life-threatening. In fact, much of the time for critical care can be away from the bedside in the discussion, thought process, and that time included into any time spent at the bedside. So phone time, and now if the provider's not at the bedside, if it's only phone time, as long as it meets the criteria for critical care, I understand that there's parity related to that as well, but I'll ask confirmation. I haven't billed any critical care in this time yet, but I anticipate that we will. And then the second question is, from Dr. Murphy, could you provide example notes or your template for your phone consult notes? And yeah, I'm happy to provide some templates, examples. They would be very similar to what I've provided in the past, either in the newsletter or on some of the webinars, but I can include some examples. Mostly they're the same notes. They're just simply attestation at the front end and at the back end pertinent to the telemedicine, and then they have to be the right type of encounter entered, not as a consult, a telehealth encounter. I've got some information particular to Epic that I can include as resources for those of you that use Epic. If there's any other
additional
if there's any other questions, please email, and I can send out. We can send out the question and answers. And I'm fortunate to have really helpful administrative support and billing and coding support here that I can bring questions specifically to them as well. And again, this is a changing landscape with updates and clarifications on a daily basis. So as this evolves, we'll try and provide updates. And if anyone is particularly successful with telehealth where you're practicing, it'd be great to get some feedback and some examples as well.
Yes, I totally agree, Tim. And also, I'm going to suggest that we have another webinar on this very topic, perhaps in about 3 weeks' time. And those members who have started their telehealth service, please contact Tim or myself, because we'd like to invite you to participate in that webinar so you can share your experiences with everyone else. I think that would be very worthwhile and of interest to our members. So for those that are going to embark upon this, please member us in terms of sharing what you've learned in your experience going forward, and we'll try to have a webinar sometime in the mid to late April to share those experiences with the rest of the group.
All right, thank you, Dr. Wax, and
okay.
All of the administrative support for putting this on. It was really very quickly put together, so nicely done. Thank you for all your help.
Yeah, thanks so much, Tim. Everyone have a good day, and keep in touch with questions for us. Thank you.
All right, bye-bye.